Okay, so good evening, everyone. So welcome once again to another PSD Select webinar. I'm Dr. Rocky Dizon, your host and moderator for this evening. So before we start, let's ask for God's guidance and blessing. So let's put ourselves in the holy presence of God. In the name of the Father, and of the Son, and of the Holy Spirit. Dear Almighty and ever-loving God, we glorify and thank you. You have showered us with so much blessings. Your presence continuously reminds us of your faithfulness and guidance. We humbly ask you to shower our speaker today of your greatest inspiration so that he may share the most of his knowledge, heart, and soul to his respective topic. May we absorb the invaluable knowledge and put it into practice what we may learn tonight. We pray that you bless all the committees in charge, that they may be able to fulfill their tasks responsibly, that the objectives that they have set may all be achieved. Your infinite blessings would mean the success of this activity. May we be living witnesses of your genuine love through the enactment of knowledge acquired through this activity. We ask these in the name of our Lord and Savior. Amen. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. Okay, so the Board of Directors of the Philippine Society of Diabetologists Incorporated welcomes everyone to this PSD Select 4, headed by our President, Dr. Danilo Baldemor, Dr. Marcy Cruz, our Vice President, Dr. Fatma Tiu, our Secretary, Dr. Jamie Agra, our Treasurer, and of course, yours truly, your Auditor. So welcome once again to the last episode of our PSD Select 4 for this year. The objective of this series of webinar is to discuss the updates in diabetes, obesity, nutrition, and COVID-19. We prepared a very short but very insightful learning activity for tonight. We hope that everyone would stay until the end of our program. Tonight, we are very privileged to have one of the senior faculty of ISDFI. He is always given the most serious and the hardest topic to discuss. And of course, we are always grateful because he always gladly accepts the challenge and invitation. To formally introduce him, he is a fellow Tamaraw. He finished Doctor of Medicine at Far Eastern University, Dr. Nicanor Reyes Medical Foundation, our faculty at ISDFI, and the head of the UERMC ISDFI Research Unit. He was the past president of the Philippine Society of Diabetologists. He finished his MS in IM major in diabetology at UERMC ISDFI. Currently, he's an active consultant at Cardinal Santos Medical Center and visiting consultant at Pasay General Hospital. Colleagues, let us all welcome Dr. Ernesto Ang.
Hi everybody and welcome to our PSD Select. Tonight, the talk is all about atypical diabetes. The title is Atypical Types of Diabetes, Looking for a Zebra in the Herd. In our practice, most of our patients are either type 1 or type 2 diabetes. And I'm sure every now and then we encounter diabetes that are in between type 1 and type 2. And perhaps we don't recognize that we are already dealing with atypical diabetes. So the main objectives of this talk is to know the importance of recognizing them for the purpose of treatment and prognosis as well. For my disclosure, I have no relevant conflict of interest to disclose in my presentation tonight. But perhaps I should first explain the subtitle of my presentation, Looking for a Zebra in the Herd. Normally, when we hear a hoofbeats, we think of horses, not zebras. And when you hear hoofbeats behind you, don't expect to see a zebra. This phrases was popularized by Dr. Theodore Woodward, an American medical researcher in the field of medicine at the University of Maryland, Baltimore. In 1948, he received a Nobel Prize nomination for his role in finding cures for typhus and typhoid fever. Woodward, or Dr. Woodward, is credited for coining these phrases, the so-called medical zebra aphorism. In giving his advice to his medical student in 1940s, Dr. Woodward meant that most illnesses would have a common causes and not rare. This observation remains relevant today and perhaps particularly to those with the diagnosis of diabetes. The majority of patients with diabetes are diagnosed as having either type 1 or type 2 diabetes. However, when encountered in clinical practice, some patients may not match the classic diagnostic criteria or expected clinical presentation for either type of the disease. So in other words, if you hear a hoofbeats, what animal would you think of? Of course, it's horse. It's the most obvious answer. Unfortunately, in the medical world, not all diagnoses are horses or the most likely possibility, and sometimes physicians need to look for a zebra, which is the less likely scenario when making a diagnosis. So, when things does not add up in terms of diabetes diagnosis, we need to pay attention for signs of atypical diabetes and therefore looking for a zebra. So, here are 3 examples of cases looking at their clinical presentation and the likely diagnosis of all these 3 is either type 1 or type 2 diabetes. For example, case 1 on your left, a 14-year-old referred for further management, diagnosed at age 11, of course, young, diagnosed as type 1, BMI normal, initial hyperglycemia with no ketone, controlled on relatively low dose of insulin and a multiple daily injection. The case 2 in the middle, a 42-year-old woman on oral medications, obviously diagnosed as type 2 diabetes and not controlled with metformin and insulin. When look at other history, presence of thyroiditis and a family history of Graves' disease. And the third case is infant diabetes diagnosed, of course, with type 1 diabetes. These are the normal clinical scenarios that you would either choose as type 1 or type 2 and treat accordingly either with insulin or oral medications. However, when look very closely and um, additional diagnostic tests will reveal uh, that this you may be dealing with atypical diabetes. So here we are. Let's talk about atypical diabetes. So atypical diabetes is increasingly recognized, but it's often poorly defined and may masquerade as type 1 or type 2 diabetes. I put up three uh, types of atypical diabetes. Number one is monogenic diabetes. Under monogenic diabetes, we have MODY, maturity onset diabetes in the young, and the neonatal diabetes. Number two, the latent autoimmune diabetes in adult or LADA. And the third one is ketosis prone diabetes or KPD. Okay, so here's the big pictures in terms of genetic of diabetes. The most common form of diabetes is either type 1 or type 2. And if you look at type 2 on your left, type 2 are polygenic, meaning they are related to change or defect in multiple genes. That's a straightforward definition. While you have type 1 and type 2 diabetes. And while the less common form of diabetes results in mutation or changes in a single gene and are called monogenic on your right. Uh, in terms of monogenic, we have neonatal diabetes, or for short NDM, and it occurs in newborn and young infant. And the other is MODY. It is much more common than NDM and usually first occurs in adolescent and early adulthood rather. Most cases of monogenic diabetes are incorrectly diagnosed. For example, when hyperglycemia first detected in adulthood, type 2 diabetes is often diagnosed instead of monogenic diabetes. Okay, so now before I leave this slide, I want you to focus on your attention on the bottom of the polygenic diabetes on your left. It's the LADA and KPD. As you can see, LADA is basically type 1 diabetes. It is just lately presented with diabetes or hyperglycemia, and because the autoimmune destruction is late, while the KPD, ketotic prone diabetes, it can either be type 1 or type 2 diabetes. Now we go now to monogenic diabetes. Okay, so the two main forms, as I mentioned, the maturity onset diabetes of the young, MODY, and neonatal diabetes. Okay, monogenic diabetes, it's a heterogeneous group of disorder involving a variety of single gene mutation in the transcription factor or glycolytic enzyme involved in beta cell glucose sensing and metabolism. MODY accounts for about 1 to 2% of all cases of diabetes. NDM occurs in the first 12 months of life, a symptom similar to type 1 but occurs before 6 months. Type 1 rarely occurs in neonates since it will take time for the immune system to destroy the beta cells. Okay, so this is the monogenic diabetes, which is a single gene defect on multiple genes that involve in insulin secretion. For example, a single genetic defect of gene expression, and the others highlighted here are more common and more important. The rest are not that super important. No? And you can see on your upper left is the genetic disorder of the gene expression, the different transcription factor. The three most common is hepatic nuclear factor 1 alpha, 1 beta, and 4 alpha. Another is the genetic disorder of glucose metabolism, which is the enzyme glucokinase mutations. Another very common is the genetic disorder of the ion channel, This is related to potassium ATP channel. Okay, so there are four important types of MODY. Hepatic nuclear factor 1 alpha, which is MODY 3, 4 alpha MODY 1, and 1 beta gene mutation at MODY 5, and 1 enzymes mutation glucokinase gene, which is MODY 2. MODY 3 is the most common of all the MODY. It comprises a little higher than 50%, which is the most common, and it's very sensitive to sulfonylureas as a form of treatment. It is a progressive insulin secretory defect with presentation in the adolescent or early adulthood. While MODY 1, the 4 alpha, it's also a progressive secretory defect with presentation in adolescent or early adulthood. The difference is that they may have a large birth weight and may develop transient neonatal hypoglycemia. They are also sensitive to sulfonylureas. Okay, MODY 5, the beta gene, one beta gene mutation is the most severe one and require insulin to ensure that the kidney cysts or uterine abnormalities don't form over time. The glucokinase gene mutation MODY 2 is the second most common. It's a little bit higher than 30%. The mutation causes a higher glucose threshold, which is known as a set point for glucose-stimulated insulin secretion. Normally, the set point of glucokinase enzymes is a blood sugar of 5 millimolar, and in mutations of the mutation of these genes leads to a higher set point, like say 6 or 7 millimolars. No? But it causes a very stable, non-progressive, elevated fasting blood glucose. Typically does not require treatment, and microvascular complications are rare. Okay, and I will show you some evidence on this later. So the question is, why diagnose monogenic diabetes? Number one, because most cases of monogenic diabetes are incorrectly diagnosed. For example, when hyperglycemia first detected in adulthood, right away we will diagnose this as type 2. And often, or sometimes we might be dealing with monogenic diabetes. The NDM, the neonatal diabetes, is often mistaken for a type 1 diabetes, but type 1 diabetes is very rarely seen before 6 months. And number 2, provides appropriate personalized treatment plan. When genetic testing confirms the diagnosis, it will be beneficial for both patients and healthcare provider. Some monogenic form diabetes can be treated with diabetes medicine, oral medicine, or pills, while other forms requires insulin. Informing family members of risk, meaning testing of other family members, may also be indicated to determine whether they are at risk or perhaps they already have monogenic form of diabetes that is passed down from generation to generation. Okay, so GCK is considered the beta cell glucose sensor, no? And the mutation of GCK is about 1 in over 1,000 people. It's an elevated threshold for initiation of insulin release. It's a lifelong stable mild hyperglycemia. A1C ranges from 5.5 to 7.5. Fasting plasma glucose, it's about 100 to 140 milligram per deciliter. Commonly an incidental finding during a physician visit or first pregnancy, or during first pregnancy. Treatment not recommended outside of pregnancy because therapy is ineffective, and lack of long-term complications compared to type 2 diabetes. So let us review a little biochemistry on enzyme kinetics in order for us to understand it better. Now, KM stands for measures of dissociation affinity, meaning glucokinase work well when the blood glucose is 5 millimolar. That's about 90 milligrams per deciliter. At 5 millimolar of blood glucose, the enzyme glucokinase start to attach phosphate to the glucose inside the beta cells. That traps the glucose and start metabolizing the glucose through glycolysis. And then it eventually generate ATP and stimulate or activate KATP channels and open up the calcium channel, and calcium enters and the release of insulin. In mode 3, which is the mutation of these enzymes, it causes a higher Km, meaning a higher level of blood glucose to initiate insulin release, higher blood glucose level for beta cell to release insulin. Now, so because of this, DCK patients, regulate their blood glucose around a stable but slightly elevated set point. Right? These people have a stable blood glucose throughout life, albeit slightly above normal level of fasting plasma glucose at about 6 to 7 millimoles. That is on your left, represented by the green dots. Okay, you can see the fasting plasma glucose. The dots is around more than 5, 6 or 7. Okay. If you give them an oral glucose tolerance test on your right, blood glucose goes up and eventually comes down again, and that's because it's regulated. The same as normal person, it will come down to the fasting level, as seen in the control groups, the black curve. The only difference between the two, the GCK and the control non-DM patient, is the level of blood glucose. The same pattern of the curve, but only slightly elevated on the GCK patient. Now, if you try to make them hypoglycemic by treating them, they get symptoms at a normal blood glucose, in contrast to people without diabetes, as seen in this graph. You can see the left side in terms of the symptoms. The control group, the people without diabetes who need to go to about 2.6 millimoles, that's about less than 50 milligrams per deciliter, before they get a severe symptoms of hypoglycemia. Okay, but in GCK, the level of blood sugar is 3.6. That's about 64, 65 milligrams per deciliter, just about 1 millimole higher. So they are less likely to develop, more likely to develop hypoglycemia at a higher level of blood glucose. And what is this so? Because they release catecholamine and counter-regulatory hormones at a higher blood glucose level. That is on your right. And you can see the release of adrenaline and glucagon at a higher level of blood glucose. That's 3.8 and 3.7 respectively, meaning you got someone with a regulated blood glucose. And the key things here is, in this patient, you cannot treat them because since they are prone to hypoglycemia at higher blood glucose level. Okay, so how about long-term complications if you don't treat? Okay, if you look at the cross-sectional, looking at A1C, treatment without treatment, the treatment here is OHA on insulin combination. Cross-sectional, the two bars here shows pretty similar. And on a longitudinal study, meaning on treatment and then you take them off from the medication, okay, look at the A1C, the difference is still the same. Okay, so there's no difference, no? If you discontinue the treatment. Okay, so how about complications? As you can see in this data, there's no significant microvascular complication except for some degree of background retinopathy, which was also found in some of the control groups. So actually, this is very few microaneurysm but no sight-threatening retinopathy despite 50 years of no treatment. Okay, so the important to diagnose GCK is to spare them from treatment. Okay, so don't use pharmaceutical therapy to unsuccessfully treat glycemia in GCK MODY. And on top of that, you may trigger severe hypoglycemia. It's okay to have an A1C of 5.5 to 7.5. Okay, so the question now is when to treat and who to treat. The answer is during pregnancy. Outside the pregnancy, the treatment is not required. However, there is a caveat here. Not all pregnant GCK need treatment. Okay, so the next question, who? Okay, the if the offspring will not carry the gene. Okay, if the fetus has GCK mutation, which has a higher set point, the circulating elevated maternal blood glucose will not trigger release of fetal insulin, hence no macrosomia. And how would you know? During pregnancy, fetal monitoring is very important, and you should institute insulin therapy if the second trimester fetal ultrasound monitoring show macrosomia, which suggests that the fetus has not inherited the GCK gene. Okay, now let's go now to MODY3, which is the most common, 52%, approximately 52%. It's a transcription factor that controls insulin genes activity, and when mutation occurs, this gene causes a gradual beta cell dysfunction and inadequate insulin production. Now look at the progression. Okay, look at the curve of hepatic nuclear factor 1 alpha MODY3, and you can see the fasting plasma glucose plotted against over time age, okay, of the patient. As you can see, over time there's a progressive worsening of glycemia. It can progress. No, studies have shown that 63% develop diabetes in 25 years, 79% develop diabetes in 35 years, and 96% by 55 years. Okay, now look at the normal curve. Okay, so the normal curve is when normal individual non-DM, when you get older, you have also some form of hyperglycemia. There's also a little progression. Okay, I mean, look at the GCK. You also have some progression, but the curve is pretty similar with normal. The only difference is the level of blood sugar is a little bit higher. Okay, but if you look at the MODY3, it's really a progressive one. You know? So as the disease progresses, in terms of MODY3, patient develop fasting hyperglycemia and diabetes symptoms. Patient with MODY3 mutation at risk for complications of diabetes. Therefore, strict glycemic control is recommended to avoid complications. So we now go to neonatal diabetes. There are two types. Okay, they call it permanent, and the permanent is a lifelong condition. The other one is transient neonatal diabetes, which can be transient, but sometimes it reappear. It disappears during the infant stage, but may reappear later in life. 90% due to spontaneous mutations. Okay, 30% represent with DKA with no C-peptide levels. Okay, 29%, almost 30%, has the DEND syndrome, the triad of developmental delay, epilepsy, and neonatal diabetes. 10% present with transient neonatal diabetes and relapse later. Majority secrete insulin in response to oral SU, so it's better controlled with SU and then insulin. So it's important to diagnose them because they are very sensitive to sulfonylureas. So what's the problem? It's the problems of the channel. KATP channel. As you can see, KATP channels, um, it's a genetic defect on the potassium ion, which is an octameric ion channel, meaning there are 4 SIR or SU receptor and 4 KER component, which is the inner rectifier or inward rectifier. So therefore, the KATP channel serves as the molecular link between changes in the blood glucose concentration and insulin secretion, and can be present and can be permanent or transient. With the mutation, there is issue with insulin secretion, and usually they are very responsive to SU. Okay. Now this data is taken from an Indian study. Children with an ion channel mutation who have been converted to oral SU. As you can see, the CGM monitoring was used to evaluate the glycemic level before and 1 month after the therapy change. The maximum SU, which is they use glibenclamide, was the dose was reached up to 0.5 milligram per kilogram body weight, and this was reduced to 0.3 milligram per kilogram body weight in response to blood glucose values. As you can see the data, before and after SU, you can see significant reduction of blood glucose levels. And this goes to show that they are very responsive with the SU therapy. Here again, another data. This is also neonatal. This is the reverse and congenital hypoglycemia. And this is also involved the ion channel. This time, genetic mutation on the ABCC8. Okay. And they used, because this infant developed hypoglycemia, they use diazoxide because diazoxide can increase release of it can reduce the insulin secretion and can cause hyperglycemia. And you can see that it works too effectively in slowing the release of insulin from the pancreas. Okay. So case of neonatal diabetes, okay, from pump to pills. This was published in People magazine sometimes in 2007. It's a Caucasian female diagnosed 1 month old with type 1 DM, okay, treated with insulin for 7 years, and genetic testing revealed eventually mutation on the ion channel and was transitioned to SU. Now 18 years old in 2007, off with the insulin for 11 years. Okay, so this just to show you that they are very sensitive to SU in form of treatment. Okay, so we go now to latent autoimmune diabetes in adult rather, LADA. Okay, so it's immune mediated. It's related to HLA association. It's linked with similar to type 1. Actually, it's really type 1. Linked to DQA, DQB genes influenced by DRB genes. It has some protective and predisposing genes, same as type 1. It also has triggering environmental triggers. Approximately 10% of type 2 diabetes were misdiagnosed, and more than 20% are over 40 years old in one UK study. So these are the different autoantibodies. The glutamic acid decarboxyl GAD65 autoantibody, which is the most common. The IAAS anti-insulin autoantibodies tend to decrease with age, okay? And they may be present and then later on becomes negative. Insulinoma antigen 2 positively correlated with higher frequency of autoimmunity and susceptible to HLA haplotype. And last one is the zinc transporter 8A. What are the criteria for the diagnosis of LADA? Okay, so it's usually the diagnosis of diabetes is more than 30 years of age, independent of insulin therapy for equal and more than 6 months. That is because it's slowly progressing beta cell dysfunction, may initially respond to non-insulin treatment. Presence of diabetes-associated antibodies. Now, when you look at the table, there are the differences between type 1, type 2, and LADA in terms of their age, occurrence, the C-peptide, metabolic function, the autoantibodies present, the circulating insulin, and time of requiring insulin. As you can see in LADA, the age group is about 30 and above. C-peptide is usually low if the patient is hypoglycemic. Autoantibodies can be present in any of these autoantibodies. Circulating insulin gradually deficient, and time of requiring insulin depends within 6 months, and it's very variable depending on the time frame. So LADA and other autoimmunity is very important to consider. The higher frequency of thyroid peroxidase antibodies, so TPO, 27% in GADA positive diabetes versus 10.5% in GADA negative. It's recommended to screen for other autoimmune disease such as thyroid disease and celiac disease if it's a Caucasian. So we go now to the last but not the least, the ketosis-prone diabetes. Okay, so KPD is a heterogeneous group, previously called flatbush diabetes, since it was first described in 1980s in Flatbush neighborhood of Brooklyn, New York, were mostly inhabited by African American. Generally has a feature of type 1 diabetes since it developed decay at the time of diagnosis and occurs more commonly in males. Since then, it was identified in many parts of the world. So why all of the confusion? Because some present with DKA like type 1 diabetes, some cases are unprovoked DKA, some may require insulin just like type 1 DM, some may not need insulin or no treatment at all eventually, which is like type 2 diabetes. So there's a lot of overlapping, and some may have cycle of insulin and without insulin, especially during DKA, which is like either type 1 or type 2 diabetes. There was several classification scheme given, but the most accurate system is the AB system. Studies have shown that it is the most accurate in predicting long-term insulin dependence 12 months after the index of DKA event. It has a 99% sensitivity and 96% specificity. The system makes use of auto antibodies, which is the A, and the B stands for the beta cell function by measuring metabolic function through C-peptide tests. The normal value are here, and the procedures you need to do both fasting and the stimulated one, but I'm not going to go over the procedures. The most important here is to do the test or perform the test 1 to 3 weeks following resolution of DKA. Okay, so KPD are patients presenting with DKA, and this is often as a first manifestation of diabetes, but they lack the phenotype of autoimmune type 1 diabetes. AB classification of KPD has 4 subgroups, and this is based on the presence or absence of autoantibodies, which is A, and beta cell function, which is B. Patient can be positive for both A and B, A plus and B plus, meaning they have autoantibodies, but they have good function of beta cells, okay? Or they have A plus or B, or they can be A plus or B minus. They have autoantibodies and they have poor beta cell function, or both A minus, B minus, without autoantibodies, but with poor beta cell function. And the last one is A minus, B plus, without autoantibodies, but with and a good beta cell function. And this is the most common type, okay, subtype or subgroup. It's a 50%. It is characterized after recovery from DKA. It demonstrated a sustained preservation of beta cell function with ability to discontinue insulin treatment while maintaining an excellent glycemic control. Okay, in terms of insulin requirements using the AB system, A plus B minus is clinically resembles type 1 diabetes, and it represents about 18% of KPD, and all we require insulin for life. A minus B minus also resemble type 1 diabetes. In ADA, you can probably say this is the idiopathic type 1 diabetes because they don't have antibodies and yet they are very poor in terms of beta cell function. It represents 20% of the subgroup. Many will require insulin for life. And the next is A plus, B plus, which resemble type 2 diabetes. A minority of the psychologists, only 8%, half will require insulin for life. You need to do some close monitoring for 2 years. So the last one is A minus B plus resembles type 2 diabetes. This is the most common. It's about 54%. No? It has two subtypes, the provoked DKA and the unprovoked. No? The provoked DKA meaning there's a stressor, usually acute illness. Unprovoked DKA, which is the hallmark of A minus B plus, meaning no stressor. It's more on male preponderance, higher rate of insulin discontinuation, better long-term glycemic control. And presenting in DKA and initial requirements of insulin distinguish KPD A plus B minus from LADA. Okay, so this phenotypic spectrum of diabetes, it's a spectrum from extreme left, which is type 1 DM, okay, towards the end of the spectrum on your right is type 2 diabetes with the classical manifestation of overweight, obese, and metabolic syndrome. In between these belong to the phenotypic clusters of atypical diabetes such as monogenic diabetes, KPD syndrome, and LADA. It occupies different regions of the spectrum that may encompasses the broad categories under which most patients are classified either type 1 or type 2 diabetes. So let's go now to the cases. For case 1, a 43-year-old woman complaining of fatigue and undeliberate 3 kilograms weight loss for over a period of 2 weeks. Okay, it's a positive history of thirst and hunger, has a history of Hashimoto's thyroiditis, and on an thyroid hormone therapy. Family history, positive for Graves' disease. The lab results show a high random blood sugar of 324 milligrams per deciliter, a high A1C of 12.1 with a normal TSH and T4. Okay, so the question is, what kind of diabetes does she have? Okay, so now the patient initially was diagnosed type 2 diabetes and started on metformin 500 milligrams twice a day with dosage increased to 1000 milligrams twice daily after 1 week, and insulin glargine 20 units every evening, titrating up to 2 units every other night to a goal of fasting blood glucose level between 80 to 130 milligrams per deciliter. Now, she returned a month or 4 weeks later in the clinic on her current dose of insulin glargine at 22 units and report documenting fasting plasma glucose level between 70 to 150 milligrams per deciliter. She notes that she gained 1.5 kilogram or 3 pounds, and her fatigue, appetite, and thirst decreased. The patient reports that she does not feel comfortable with her diagnosis and requests referral to specialists. Moreover, patient asks if he can get away with insulin. And with this, additional test was done to answer the patient's request. And a diagnostic test on pancreatic islet cell autoantibody panel and C-peptide level shows a positive GAD 65 and a low C-peptide level. Okay, so type 2 diabetes account for approximately 90 to 95% of cases. Therefore, it is easy to suppose that middle-aged and older adults who present with new onset diabetes have type 2 diabetes. However, between 5 to 10% of adults diagnosed with type 2 diabetes may be misdiagnosed and may have LADA. Okay? Individuals with LADA also tend to be slimmer than patients with type 2 diabetes. Although they are not exempted, some may have overweight and obese. LADA have a fewer metabolic features as dyslipidemia and overweight obesity compared to type 2. Family and personal history is very important. Looking for autoimmune diseases. Family history of diabetes does not appear to play a big role in LADA compared uh, to type 2 diabetes. Further clues for this patient had normal weight and presented acutely with classic symptoms of hyperglycemia, which is more commonly seen in autoimmune disease. No family history of diabetes. Okay, she did have family and personal history of autoimmune thyroid disease. No features of metabolic syndrome. Okay, additional her A1C was markedly elevated, which is more common initial presentation of patients with type 1 or LADA than those with type 2 diabetes. Now let's go now to case 2. A 44-year-old Hispanic man presented with DKA, no prior history of diabetes. He has a polyuria with 13 kilogram weight loss over a period of 1 month. Past medical history, non-significant. Family history, both parents and sister with diabetes and on oral medications. No smoking history, an occasional alcoholic drinker. BMI of 36, mild acanthosis nigricans on neck, central obesity, and there's no evidence of infection, CAD, CVD, renal or liver dysfunction, drugs and alcohol exposure that may trigger DKA, meaning this patient developed unprovoked DKA. So the standard treatment for DKA was given, and it was an uneventful recovery, and patient was discharged on insulin. Okay, so after 3 weeks, further studies was done and shows that autoantibodies is negative and C-peptide is normal. Okay, so what kind of diabetes does he have? This patient have DKA. Okay, so so the answer is A minus B plus KPD. So the diagnosis is A minus B plus. Okay, there are two subtypes based on provoked and unprovoked DKA. Now it's important to distinguish the two, since the unprovoked KPD, the beta cell function is more stable and insulin independent for maybe for more than 4 years, and it is also more common in male. While the provoked one is characterized by progressive decline in beta cell function, require insulin within 2 years in duration. Okay. So my original intention is to give more cases. Unfortunately, time allocated to us does not permit that. So I just included the most common one. And FYI, in case you are dealing with in between type 1 and type 2 and you're looking for a zebra, there is an app that you can use. It's downloadable and it's called Diabetes Diagnostics. Okay, you just have to fill out some patient information such as age of diagnosis, current age of the patient, gender, race, BMI, etc., even A1C, and then additionally the time of insulin treatment if the patient is on insulin, and other features, and it can give you some answers. And so, in conclusion, the next time you hear a hoop beats, there may be indeed be a zebra among the herd. So with that, I would like to thank the PSD people who invited me for this presentation, and also thank you for tuning in and patiently listening to me. Thank you so much.
All right. So thank you very much, Dr. Ang, for a very comprehensive lecture on atypical types of diabetes. So again, as a clinician, we are once again reminded to think outside the box. And this is actually very timely as we prepare for upcoming ISD convention with the theme Realm of Diabetes, Thinking Outside the Box, which will be happening on October 27 to 29, 2020. So I'm sure we all enjoyed and learned from Dr. Ang's lecture. And at this point, Dr. Ang is actually ready to entertain our question. So if you have any questions, please type it on our chat box, or you may click the raise hand icon and wait to be acknowledged before you unmute your speaker. So good evening, Dr. Ang. Hi, sir.
Yeah, good evening.
Hi.
Good evening to all again. Yeah, so if you have some question, I will be willing to answer your queries. We have 4 minutes to go.
Yes, sir. Actually, talagang pag mahirap at seryosong topic, Dr. Ang talaga ang katapat niyan, sir. So, just to begin with my question, sir, for patients which we suspect to have atypical diabetes, where can we refer these patients for genetic testing? Do we have it in our country?
Yeah, that's a very good question. Actually, wala tayong genetic testing dito eh. We have to send it to Singapore or somewhere else. What we have is the antibodies. In fact, if we look at, if you read about articles about LADA, I'm talking about LADA, for example. HLA is not an important test. The antibodies, the autoantibodies is more important. So on and off, we have GAD65 antibodies that you can request at Global, St. Luke's, but every now and then nawalan sila ng reagent eh. So I asked that several years back, and even recently we don't have in Cardinal, but we can send it to St. Luke's. No? So you can ask for you can request for that test, perhaps maybe St. Luke's, Quezon City, or Global.
All right, sir. Yeah.
Try your luck.
Yeah.
But
I think
IP definitely we don't have.
Yeah. I think high precision, sir, which could be seen everywhere. They have, I think, C-peptide, no?
Yeah, yung metabolic test is very commonly
Available.
Available yan. Okay? Pero
Yes.
yung autoantibodies, yun yung may konting difficulties.
Yeah, I agree, sir. So I think Dr. Rima is raising her hand. Yes, ma'am.
I think sa St. Luke's meron, at saka sa high precision meron din na yata eh. So,
Autoantibodies?
from Manila lang. May selected.
Autoantibodies?
Parang may autoantibodies na.
We just recently asked, wala eh.
Wala ba? Okay. So, C-peptide lang ang meron sila.
Yung metabolic, like insulin assay and C-peptide, these are metabolic, which is readily available. Even in our local hospital, it's available.
So without the test, Ernie, clinical lang talaga tayo. Kumbaga, we'll just wait and see what happens if they will eventually, if we can take them insulin or yung mga ganon. Clinical lang lalabas.
The sad point is mahirap gawing clinical eh. Especially the syndrome of KPD. It's really difficult to just diagnose it to clinical. That's the standpoint. Okay. Pero ang autoantibodies, the most important is GAD65, which is the most important and the most common. And it's available every now and then.
Sabi ni Nine sa chat box, meron daw.
God
Parang
65 daw. He just requested daw po sa high precision. Well, that's good to know. Thank you, Doc Nines.
oo.
Saan yan? Yung
High precision daw,
God
sir.
65? God 65?
God
Auto
65.
antibody.
Well, that's very good to know. We have a question here from Dr. Marcy. Do we have to test for C-peptide to know if patient with adult can be a typical diabetes?
If you're suspecting an atypical, one of the tests is the metabolic function. If the patient's beta cell is still secreting insulin, and that is through C-peptide.
Yes. So
Yes,
through
the answer.
C-peptides, or at least we could somehow differentiate now if it's really atypical or a type 2 diabetes, because for type 2 diabetes, we somehow expect the C-peptide to be normal to elevated. You mentioned, sir, a while ago about KP.
Now you have to be very careful with the evaluation or
Yes.
interpretation of C-peptide. Okay?
Correct.
It depends on the blood sugar of the patient. And so you have to do the fasting and the other one, the what do you call that? Yung stimulated.
Test.
Stimulated.
Correct, sir. Sir, you
Upper
mentioned, you mentioned, sir, a while ago the ketosis-prone diabetes, no? Ang mahirap kasi sa kanila, parang they can be off to insulin, and then after a while, bigla na lang DKA ulit, no? Can we at least maintain the patient on a low-dose basal insulin among patients with KPD in order to avoid sudden development of DKA?
Yeah, I will do that. I will do that because even if we have autoantibodies, not all patients can afford to do that. Okay, and sometimes if you do anti-God, minsan nagne-negative eh. So it's advisable to give a low dose insulin clinically so that they don't develop a DKA, or that the insulin can maintain the blood sugar at a normal level or optimal level.
Yes, sir. So, thank you. So, meron pa bang nagre-raise ng hand dyan? Hindi ko masyadong nakikita. Lynn, Doc Danny, please help me. Sir, kanina na-mention niyo po yung glucokinase, no? Yung GCK. Especially incidental finding siya sometimes, no? Sa mga pregnant patient natin. And you mentioned na somehow, tinitreat natin siya during pregnancy, pero meron ding small subset na hindi natin siya, na pwede namang hindi i-treat during pregnancy. Is that right, sir?
Yung outside of pregnancy, there's no quarrel, no? You don't treat because, as I mentioned and I presented, that even the blood sugar is slightly up, it's rarely produce or develop, this patient rarely develop diabetic complications, okay? Over 50 years or even many, many years, no? And in fact, if you treat them, they are very prone to hypoglycemia, and especially severe hypoglycemia. So no treatment. Now, when do you treat, and what are the patients that you have to treat during pregnancy? Sometimes this pregnant individual, when they do OGTT, makikitang mataas eh. So they would say that this patient may have GDM. Okay. Now, if the pregnant female and the fetus, okay, kasi yung genetic transfer is not homozygous, no? It's heterozygous. So not meaning the fetus is not always will inherit the GCK mutation. Now, if the fetus or the baby acquire the mutation with a higher blood sugar threshold or set point, so it will not release insulin. Kung hindi lang naging na-inherit yun, normal yung fetus, and the pregnant women has GCK, mataas yung blood sugar at mag-stimulate yung insulin ng baby at lalaki yung baby. And how would you know? So you have to monitor the fetal weight of the baby. If
the fetal weight of the baby is increasing, and then most likely you need to treat the patient with insulin so that the baby will not become bigger. You know, so it depends on the fetus if they will inherit or they would not inherit the GCK mutation.
Yes, sir. So actually, no, yung body kasi, sir,
Diba?
yeah.
O hindi naintindihan?
Clear naman, sir. Yung MODI, sir, actually yung MODI 2 na to, medyo gray zone ng konti kasi outside pregnancy, no, pag tinreat mo siya, at least siya for hypoglycemia. And of course, in the practice of medicine is do no harm, okay? Although yung kanyang sugar, sir, is typically is higher than the usual. Paano natin, sir, madi-differentiate kaya tong MODI 2 na to? Especially if we don't have a genetic testing, what clues can we actually look at into our patients if actually they belong to MODI 2?
If we have the if we can test for autoantibodies, God, kung may available yon, and that would give us an inclination, and the apps will tell us the apps that I gave you.
Yeah.
You can put in all the information, and they will advise you or will tell you something like kung ano ang most appropriate diagnosis for an atypical. Let's say kung sabi niya MODI, and then you do meron ani niya din sasabihin niya rin kung anong test ang kailangan. And if it's positive, then maybe you can diagnose it GSK MODI.
Yes, sir. I would like to thank you, sir, doon sa app na binigay mo sa akin, sa amin kanina, no? Actually, pinaglalaroan ko na siya. So I tried to put some data. So halimbawa, sasabihin niya dito, the most likely diagnosis for your patient is, and then meron siyang lalagay dito na the probability of your patient having MODI is blank %. So somehow, sir, no, at least we just have some idea po if we need to entertain the possibility of MODI. So I think we have another question here. How old is the earliest you can give STU? Like in the case, I think he started at 6 years old or 7 years old. Can all SUs be given? I think this is from Dr. Faye de los Santos.
Yeah, actually, I included the neonatal, although it's not the realm of our diabetologists, it's more on endocrinology, pediatric endocrinology. I just included that for completeness. The important things there is if the patient have diabetes or hyperglycemia during the period of within 6 months, that should not be type 1. That is neonatal. And as I mentioned, it's more on the mutation of the potassium ion channel rather. And as far as the question is concerned, as far earliest to give SU, I don't know the recommendation of on what age would SU be recommended to treat hyperglycemia. But in the data that I presented, Indian data, these are infants. So they compute per kilogram body weight. They compute, in fact, they use glibenclamide. And they found out that it's very effective in using SU in this kind of patient compared to insulin. As you can see the data before and after, or comparing insulin with the glibenclamide is significantly lower. You can see the insulin therapy is 200, 300. When they shifted to glibenclamide, went down to less than 100, okay, or 100 plus. Okay, so I think you can give it, but this is again in the realm of pediatric endocrinology.
All right, sir. Is there any specific SU, sir, that would favor for the MODI? Is it glibenclamide, glycoside, or glimepiride, or any kinds of
Wala.
SU?
Siguro any SU. Any SU. Kasi ang problema niya dun sa potassium channel. I guess, although I've seen some articles using other sulfonylureas, but the one I presented, because they have the complete data, the Indian study, they use glibenclamide.
All
But
right.
other
Thank you.
articles I've seen, they use other SU.
They use other SUs. Okay, but the most thoroughly studied, sir, is normally glibenclamide kasi ito yung nauna before, no, sir?
Nauna, yeah, nauna.
Oh, okay. Dr. Rima is asking for the copy of the link. So, ma'am, will try to send it po
Copy
doon sa
of the-
Viber group. Opo, yung link,
Copy
sir,
of
for
the-
the app. Yes po.
Copy of the
Yung link natin, sir, for the yung application na binigay.
apps.
Yeah.
Okay.
Yung link lang, di ko nakuha eh.
Yes, ma'am.
May bayad yan, may bayad.
Hehe.
Okay. So, any other questions? May nagre-raise pa ba ng hand? Okay, I think wala na. I think we have tackled a lot of questions already. And at this point, let us thank Dr. Ernesto Ang for the very comprehensive lecture on atypical types of diabetes. Sir, the knowledge and expertise that you shared with us tonight would surely create an impact to our clinical practice and I hope further improve the lives of our diabetic patients. So before we end, we proceed to some reminders and announcement. May we request everyone to please open your camera for picture taking. Okay, Lynn, let's have our picture taking.
Okay po, doctors. Pa-open na lang po ng camera. Okay po. 1, 2, 3. Smile. Thank you po. Isa pa po. Isa po. Okay po. 1, 2, 3. Thank you, doctors.
All right, so thank you very much for opening your cam for our pictorial. So before we end, just a reminder that we have only 6 days left to avail of the early registration rate to our annual ISD convention. So a face-to-face early registration rate of 3,500 pesos is only up to September 30, 2022, whereas the online or virtual registration of 2,000 pesos is until October 27, 2022. And if you have any questions or concerns with registration, please feel free to contact our help desk officers, Ms. Ann Reyes or Ms. Nimla Ravelo on the contact numbers provided on your screen. So we hope to see everyone face-to-face or virtually on October 27 to 29, 2022. Thank you very much, everyone, for joining us tonight. Stay safe and good night. Thank you po.